So to summarize what I'm going to talk about, diabetes insipidus can occur at the onset of diagnosis of LCH, or it can occur at any point later in the course of the disease or after the completion of treatment. In patients with multisystem disease, it appears to happen to almost half of patients. Risk factors include multisystem LCH and craniofacial lesions, and systemic treatment with chemotherapy may reduce the risk, but we don't really know, and we're doing a clinical trial to answer that question. In terms of neurodegenerative changes, that appears to have a later onset. Various series have reported it from being anywhere from about 5% to 25% of patients. Risk factors again include multisystem disease and craniofacial lesions, and then patients who have involvement of the hypothalamus or pituitary with growth hormone deficiency or other endocrine changes. There is no clearly effective therapy, and you can be completely without symptoms but have these changes that get worse over time, and these patients require close follow-up. So, where we are now in 2007, we need to better define what this disease is, collect more information by doing follow-up serial MRI studies, by doing neuropsychological testing in these patients to very carefully quantify what the abnormalities are, and to carefully look at the endocrine system in these patients. At a more basic science level, we need to try and understand why diabetes insipidus even occurs in LCH. We don't really know. And then we need to develop treatments which can either prevent the development of DI or prevent the development of neurodegenerative disease. But I think we're still quite a ways from that. And so I'm just going to mention that you're going to hear in the clinical trials session tomorrow about the LCH CNS 2003 study. This is not a treatment study. It's really a registry study that makes recommendations for evaluation. And patients are eligible who have a biopsy-proven diagnosis of LCH, and on MRI they have some evidence of central nervous system involvement. And this study provides guidelines for doing these MRI studies, for doing the neuropsych testing, and the endocrine evaluations. So there's probably no obvious benefit to you or your child if you're eligible to be in this study, but it will certainly make a difference for future generations. And I would encourage you to ask your physicians about this study. And if it's not available at your local institution, contact the association office, because there are institutions around the country that can help provide this evaluation. I want to thank Nicole Groix, who I think most of us would acknowledge is clearly the world's expert in this area. She provided much of the data for this talk and some of the slides. And I'll take a couple of questions if we have sufficient time. Regulation of sex hormones is controlled by that same area of the brain. And so some patients who may have diabetes insipidus and or growth hormone deficiency and or thyroid dysfunction, all of those things are regulated by this part of the brain. And so hormones are made in that part of the brain that regulate production of testosterone and estrogen and those other sorts of things. And so in some patients with LCH, usually patients who already have DI, those hormone levels, production of those hormones can be affected. The levels would be low, and patients might not go through puberty or might have a very delayed puberty. And so that, again, I think that evaluation as a part of long-term follow-up is important, and I'm sure we're going to hear more about that in the next talk. Well, that's a great question. You notice I didn't really address that because there aren't any clear guidelines. I think if I were a parent, I want my child to have an MRI scan every 6 weeks to look for that, but that's not really practical. And particularly in younger children, it's not really safe because younger children require sedation for that procedure. So I think we have to balance with our clinical judgment as best we can which patients are at risk and when those scans ought to be done. I think if a child has a risk for developing that, like a craniofacial lesion, I think an annual MRI scan is a reasonable thing to do. If your child does not have a risk for that, if maybe there's a lesion on top of the skull, that the risk there is very slightly increased. And I don't think that we can make a clear recommendation that an annual MRI scan to look for those changes is going to be indicated. The other thing that I would mention, at least for now, is that it's not going to necessarily change what we do because there is no effective therapy. So one could be very aggressive in looking for these lesions, but what's going to be the consequence, the result of that? If we find it, all we're going to do is continue to monitor the patient closely because at the present time we don't have any preventative therapy to offer. So, hopefully at some point in the future we will have some sort of strategy to prevent or treat this. And in that setting, it may be much more important to be aggressive about looking for those changes. Well, I think pineal gland involvement is much less common, but because melatonin can be involved with the pineal gland, that was one of the rationales for using that as a therapeutic treatment. But it seems to be, pineal involvement seems to be much less common than hypothalamic or pituitary involvement. So I think that endocrinologists would be the doctors who would look for all the endocrine problems. At my institution, if I have a patient who I suspect has diabetes insipidus, I will refer them to the endocrinology clinic for a water deprivation test, and they'll usually see an endocrinologist. And they can, the test for thyroid deficiency is a simple blood test. The test for sex hormone deficiencies is a simple blood test. The test for growth hormone deficiency is a little bit more complicated blood test, but typically we would only do that in patients who seem not to be growing properly. In contrast, the neurodegenerative changes are not something that an endocrine doctor would typically be involved with. And so I think you would look to your oncologist to sort of supervise that. And if the patient, certainly if the child develops symptoms, the things I talked about, tremors or loss of balance, difficulty speaking, maybe cognitive problems, a neurologist would be the right person for that child to see. Yeah, so that would not be considered a risk lesion. And so patients with involvement in those areas seem to have only a very slightly higher incidence of diabetes insipidus than patients in all LCH patients. I don't think we can say with certainty. Again, it's a very new area. It's not well defined. I think your child would be a great candidate if she's had diabetes insipidus or some of these other problems. She's not going to be eligible for the CNS 2003 study, but these risk factors are not absolute. I mean, there can be patients, I think, who could have neurodegenerative disease who don't have diabetes insipidus or craniofacial lesions. So that's something that you should discuss with your physician about whether an MRI or neuropsych testing or both might be indicated.